Either or. Don't dig too deep. It looks shinier on the top.
Yeah. Okay, I might get started now. I can still see people are logging on, but hopefully by the time I finish introducing you, then everyone who's going to be here will be here. Okay.
Sure.
Hello, everybody. It's a pleasure beyond compare to introduce Dr. Chris Verschoor to you today. Chris Verschoor got his PhD at the University of Guelph in 2010, and it was an absolute joy to have him as my first postdoc between 2010 and 2015, where I still call it the Chris Verschoor era because he was just so fabulously productive and collaborative that it really got my lab started, and I'm forever grateful for that. After he spent some time in my lab, he worked as a research associate at the CLSA, where he really got heavily involved in work with the CLSA. And that has been incredibly informative and useful and wonderful and collaborative. And he's published some really great work looking at so many aspects of healthy and unhealthy aging. He joined the Health Sciences North Research Institute in 2019, where he still is working as a research scientist. And the thing that you really need to know about Chris is that his work in vaccination, in like large data sets and complex analysis, makes him the world's most sought out collaborator in this field of aging, immune responses, vaccinations, and other things. In fact, I ran into at a conference George Kushel, who's sort of the world leader on vaccinations in older adults. And he said, I think Chris is the best person I've ever worked with, both because of his technical expertise, but just because how kind and nice and helpful he was. And the other thing about Chris is he's got a tremendous history of mentorship, all levels of undergraduate trainees. And they all go on and do really wonderful things and are so grateful for that. So he's been funded by the CHR, by the Canadian Frailty Network, by institutes outside of Canada. So he's built an international reputation. And I'm so glad to be getting sort of a first view of the work that he's doing now on this project, because his ability to use databases really help us understand the big picture risk of infections and the benefits of vaccinations that I think are so applicable to people living with chronic lung disease, older adults, and frankly, the rest of us. So with that, I'm beyond thrilled to introduce Chris Verschoor to this audience. Thanks, Chris.
Thank you. And nobody gives a better introduction than Don Bowdish. So thank you so much, Don. And yes, I'm really pleased to be here. There's a big space in my heart for McMaster and the Firestone and anything that has to do with lungs. Today, I'm going to talk a little bit about infectious disease and health outcomes in older adults. This is a project where we're using ICS. Was my first real big foray using ICS data, and it opened my eyes in a lot of way, not only to the complexity of the data, but the impactfulness of ICS as a resource. So anyways, I hope this is really informative. So I'm coming to you from Health Sciences North Research Institute. If you don't know where HSNRI is, we're in Sudbury, Ontario, so about 5 hours north of you. So I'm a scientist there. I also hold faculty positions with NOSM University here in Sudbury, in the Department of Medicine at McMaster, as well as at Laurentian University. So let's get my slides going here. There we go. So I have no conflicts of interest to declare. So where I'm going to start today is something I think everybody knows very well, particularly since we're getting into our post-pandemic years, is that the burden of acute respiratory infection, particularly lower respiratory tract infections, is massive in older adults. So globally, we're talking, 1.2 million deaths per year accountable to lower respiratory tract infections, 22 million disability adjusted life years. So those are dailies. If you don't know what a daily is, it's essentially The total number of years lost due to impairment, so that's not death, it's just living with impairment, which is in many ways is a severe outcome as death for some people, and this specifically in the 60 and older group. In Canada, we have very similar trends. So what we are looking at on the right here, this is data from the Global Burden of Disease Study. This is specifically in Canada. On the top, we have deaths, and on the bottom, we have dailies. And we can see for lower respiratory tract infections and COVID-19 on the right-hand side is that, the number of these events increased sort of precipitously around 70, 75 years old. With COVID, it was a little bit earlier. Dailies had very similar trends. So we know that in Canada that this is a major problem, and it has been for a long time, and that's not going to change. The leading causes of infection are streptococcus pneumonia, so the cause of pneumococcal pneumonia primarily, SARS-CoV-2 obviously, so COVID-19, influenza, entero, and rhinoviruses, and then respiratory syncytial virus, or RSV. So one thing about ARIs that is interesting coming from it, from an aging lens like I do, is that, I find it amazing. A lot of people still believe that acute respiratory infections are self-limiting diseases. So if we look at the top here, you have an infection. It could be severe enough that the person needs to be hospitalized. We have these outcomes that we commonly measure in hospital. But then the person is discharged and away they go. They're back to life and we assume that everything's okay. In older adults, that's not necessarily the journey. So what I'm going to show you here, this is data from Melissa Andrew, geriatrician at Dalhousie University. She published this a few years ago, and what they were looking at specifically here is a cohort of older adults that were admitted to hospital with influenza or another type of ARI, and then specifically looked at the ones who survived in hospital and then were discharged. And specifically, after discharge, they followed them for 30 days, and they were looking at functional impairment. How many of them maintain their functioning according to the Barthel Index, which is a count of essentially your functional status, your activities of daily living, being able to bathe yourself, personal hygiene, feed yourself, those sorts of things. And what they found is of the adults that were discharged, about 73% of them maintained their function for 30 days after discharge. However, about 18% of them had a functional decline. The rest, the balance of that had passed away in hospital. And of those who had a functional decline, about half of them were a moderate functional decline. So this is a 10 to 20 point decline in the Barthel Index, whereas the other half had a catastrophic decline. So this is a massive loss of function, enough that might push an older adult to needing, round-the-clock assistance such as long-term care. So that is pretty astounding. And keep in mind, this is only 1 month after hospital, so we can't consider this necessarily long-term outcomes, but there are others that need to be considered. One area is cardiovascular outcomes post-discharge. So this is data from a study that was just published this year in the American Heart Journal, and specifically they're reporting on data from the CAN-CHD. So this is a congenital heart disease cohort, Canadian cohort. And what they wanted to look at is individuals hospitalized for influenza as compared to a control group, a bone fracture group. And they're specifically looking to see these individuals with congenital heart disease, when hospitalized with influenza, post-discharge, how many cardiovascular complications did they have? So this wasn't any specific type, this could have been an infarction, atrial fibrillation, so on and so forth. They were just interested in looking at the incidence of that event. Now, specifically for influenza, you can see that in the red bar here over time as compared to this control comparative group, the bone fracture, and you can see that indeed significantly higher post-discharge. And if we look here on the right, we can see that the incidence is different for more or less about a year after discharge. So up to a year after these individuals were hospitalized with influenza, their journey is not over, and they still have a major amount of risk associated with them, specifically for cardiovascular complications. A better known study was published a few years ago now by Jeff Kwong, who's at U of T, and he published this in the New England Journal. And what they were doing here is they specifically looked at individuals who had a laboratory confirmed influenza infection. So this could have been in hospital and not necessarily in hospital. But specifically, they looked at individuals who had an influenza event, and then they looked within 1 week later to see if they had a myocardial infarction. And what they did is they compared that to individuals that had a myocardial infarction outside of this 1 week window. They called it a control window. So essentially, they're comparing people who had infarctions and then when did they or did they not have a laboratory confirmed influenza. And what they showed was very interesting. Within 1 week of a laboratory infection, the incidence of an infarction was 6 times higher. And that dropped off quite precipitously after that week. So we can see here that after the laboratory confirmed infection, that there is this risk of cardiovascular outcomes. What's also interesting is they looked at what they call alternative exposures, so other types of pathogens that they may have been infected with, one of which being RSV or respiratory syncytial virus, and that was about 3.5 times higher. So we have another type of infection that seems to be driving this cardiovascular complication post-infection. Let's talk a little bit about RSV. So I'm not a virologist. I play one on TV, so to speak. But I do know a couple of things about it. I know that it's a single-stranded negative sense RNA virus, so very similar to influenza in many ways. It's a very, very common cause of respiratory illness in North America. So, speaking to the group here, I think this is probably well known. It's really often mild, but it can also cause significant disease. And as far as who is often seen as more at risk, we can see here, this is data from the RSV net, and this is from the Centers of Disease Control in the US. And we can see that it's this pediatric group. So children 0 to 4 years old, most likely to be hospitalized. And over the years, this is where most of the focus and research has been placed. And in many ways, the next highest group, the 65 plus, have been underappreciated when it comes to RSV infection. So yes, in many ways, it's been a second fiddle to other viral infections, at least. So when we consider it compared to, say, influenza, we're usually only seeing 10 to 30% the number of cases per year in older adults. Now, that depends on the year, of course, and it depends on the setting. We see here, this is data from a Finnish registry study, and what they were looking at is different types of infections. This is pre-pandemic, so this is SARS-CoV-2 here. This is when everything just went upside down, but we can see here, year over year, the different flu seasons. We can see influenza A cases, we can see influenza B cases in red, and we can see in RSV cases. And really the takeaway here is no, RSV is not as incident as either of these influenza subtypes, but it differs from year to year. Some years it's very low, and some years it's actually quite high, and recently it has been very high as well. Another thing about RSV, which may change this picture in a lot of ways, is that it's commonly underdiagnosed. So in a study between 2016 and 2019, this was a study of American hospitals, they found that the testing differed depending on the setting. So if you were in a large hospital or a teaching hospital or an urban hospital, you were more likely to receive RSV testing if your case indicated for it. So community hospitals, rural hospitals, things like that, less likely to have the capacity to test for RSV. In a Danish study, this was between 2015 and 2018, what they actually did is they compared they looked at laboratory confirmed RSV hospitalizations, and then they looked at the registries for those same patients. So essentially they looked at their ICD-10 codes, and they found that 60% of laboratory confirmed hospitalizations were not registered with an appropriate ICD-10 code. So studies like the one I'm about to show you, so inherently a bit of a limitation when doing sort of register studies and administrative data studies, is that there may be an underdiagnosis of RSV that needs to be seen as a limitation. As a whole, really, we can see that, RSV is probably a little bit more significant than we think it is as far as the incidence. what about the actual severity of the disease itself? And this is where things get really interesting and important as well. There have been a few studies that compared RSV hospitalizations to influenza hospitalizations in older adults. And what they found in comparison to influenza is that generally RSV was associated with a longer length of stay, greater need for mechanical ventilation, greater incidence in pneumonia, increased mortality post-discharge. And that's this chart here. We can see a difference in the survival of RSV patients and influenza patients post-discharge. This goes up to one year post-discharge. And also, there's a bit of a caveat there too. So many layers of this onion that I'm pulling apart. RSV patients, while their stays are more severe, they also themselves seem to be a little bit different. So RSV patients tend to have greater comorbidities. So you'd expect to see a higher prevalence of things like asthma, COPD, and heart failure. And this is what I'm going to show you in our study. So this is mostly what is well known about RSV in a hospitalization setting as compared to influenza. It seems to be more severe. I've already spoken to you about more longer term outcomes, like cardiovascular outcomes. This isn't well known, so this was the impetus of our study. So our research questions were as follows. First, what is the incidence of cardiovascular outcomes in patients admitted for an RSV-related hospitalization? This was up to 1 year following discharge. How does this compare to influenza or other types of admissions? And thirdly, does this differ in patients with or without prior cardiovascular conditions? So you'll see in our table 1 that this is a pretty important point. So as far as our study design, so as I mentioned before, this is a study using data holdings from ICS. We used these databases here. I'm not going to explain them because if you don't know ICS, you may, or CIHI, you probably don't know the databases. Our inclusion criteria was pretty broad. So our admissions were between 2011 and 2020 that we considered, and adults 65 years and older. Our exclusion criteria included adults admitted outside the period in which RSV or influenza were circulating in a given year. So we only considered those admissions every given year between, say, around October to April, May. And we made sure to check year to year when were the RSV and flu season. And keep in mind, RSV tends to circulate a little bit earlier than influenza does. We didn't take anyone admitted from long-term care, obviously no Ontario residents because this is ICS is an Ontario database, and we didn't take anyone hospitalized in the previous 2 weeks. So we were trying to get people who were admitted with community-derived infection instead of nosocomial. And we didn't take anyone admitted to hospital that did not admit at least one patient for an RSV-related illness in a given year. So what that means is if a hospital had, say, influenza patients in a given year, but they did not have any records of an RSV patient, we assume that that hospital wasn't testing for RSV vigorously, so we didn't consider that hospital or those patients whatsoever. And this will become more obvious when I talk about limitations further on. So our cases, those were identified using previously validated ICD-10 codes. These are patients with an RSV or influenza as the admitting diagnosis. Now, we didn't want to just have influenza as the comparator group. We want to go a little bit further, mostly because you have the power in ICS. So we used 2 other comparator groups. First, we used a comparator group of people hospitalized with a urinary tract infection as a most responsible diagnosis. So this is a group of individuals. This is not a respiratory infection, but it is an infection. So I thought it would be kind of interesting to have a look at something, a case where there's infectious etiology, but it's not respiratory related. And then we had another group of orthopedic fracture patients. So these are patients, obviously no infections. They should be very, very different in their indications when they presented. So we thought this would be a very good, alternative exposure group, very different from RSV. Our outcomes were primary outcomes were admission 1 year post-discharge for Any of these four conditions, so heart failure, myocardial infarction, stroke, atrial fibrillation, and our secondary outcomes were mostly those in hospital and near discharge. So 30-day mortality or readmission, transfers to ICU or specialized care unit, whatever you want to call it, and length of stay. So as far as our statistics, we use mean standard deviation or median IQR and count and frequency for summary. And we compared characteristics of the patients using a standardized difference or the D metric. Our outcomes, what we did is use a match design to compare RSV patients to our other three comparator groups. So how that worked is we first did pairwise exact matching on year of admission and hospital. So RSV patients would be compared directly to the other groups only if they were at that hospital for that given year. And then we use propensity score matching on patient characteristics, which you'll see in the next slide to further the exactness of the match. Our primary outcome differences were estimated using the proportional hazard models and a robust sandwich variance estimator to account for the matching. Our secondary outcomes, they differ depending on specifically what we were looking at. So use hazard models, conditional logistic regression, or in the case of length of stay, we used Poisson regression. And then we also did the stratification on cardiovascular conditions. So we had our entire patient group, but then we also split them into patients that had at least one cardiovascular condition prior to admission, and then patients that didn't have any. So this is our cohort summary. This will be in 2 slides. So we have here, the columns are our RSV patients. We had about 3,000 altogether over the 9-ish years of the study, about 18,000 influenza patients, about 72,000 UTI patients, and about 9,500 fracture patients. We have these different demographics, geographies, and so on for the rows. And then specifically what you should look to, because obviously this is a very busy slide, is look to the column D. So this is our standardized difference. And what it means is the difference between the given comparator group and the RSV group. If it's bolded, it means it's more significant. So generally a D of 0.10 and above, we consider as being a relevant difference that we need to consider. So just looking at the differences here, we can see that our RSV group was slightly older than our other comparator groups, actually much more than the fracture group. We can see there's a bit of a difference in the female-male sex ratio. So, a few more higher percentage of women in the RSV group compared to others. If we move down, we can see there's a bit bigger difference as far as northern residents, which is obviously of important context to us up here in Sudbury. We can see that a relatively smaller number of individuals, patients came from the north as compared to the other patient groups, and this would make sense based on what I had mentioned about how RSV testing can be biased depending on the hospital. Rural residents was somewhat similar. Some differences in frailty score, not necessarily between influenza and RSV, and then some differences in influenza vaccination. Now, the next slide is, again, cohort summary. This is prior chronic conditions. So this is where we saw very, very big differences, which made us sort of jump back, and we had to think a little bit about how we would do the analysis. Again, it's the exact same layout as before. What we see here are conditions such as asthma, COPD, heart failure particularly, and atrial fibrillation are much higher prevalent, so much more prevalent in our RSV patients compared to others. So we can see asthma at about 34%. That is higher than influenza at 28. We can see COPD is at about 54% compared to 47 influenza. The prevalence drops off quite markedly for the other two groups. Heart failure at about 36%. And atrial fibrillation at about 36% as well. Now, there were a lot of other chronic conditions that were very high as well. So about 43% diabetes, for example, dyslipidemia is about 46%. Although these didn't differ quite as much across the patient groups. So, I mean, this really, supports what has been previously shown in the literature that RSV patients definitely are a little bit different as far as their prior chronic conditions. And this is important because it would obviously speak to the severity of the disease as well. And then obviously the importance of using our the match design for doing the analysis. So this is the summary statistics of our outcomes. So we have separated into primary outcomes here and then secondary outcomes below. Again, our four patient groups. We can see that most of these outcomes are higher in the RSV group. So 14% were reported to have a incidence of heart failure within 1 year post discharge. 2% for infarction, only 1% in stroke. This actually was not different across the groups. And we'll see that on the next slide. Atrial fibrillation was slightly higher. As a whole, though, when we look at all the groups, about 22% of RSV patients had at least one of these events occur a year post-discharge. And that was higher than flu at 19, UTI at 15, and then fracture at about 9%. Secondary outcomes were about the same. They were generally higher for RSV patients. We can see here that about 18% required an ICU transfer, and about 14% died within 30 days post admission. So what I'm going to show now is the outcomes analysis, which will support what you saw on the last slide. This is going to be broken up into three chunks. First is what I'm showing here is all patients. And again, this is a very busy slide, so I'll sort of walk you through it. What we have here on the far left side are the three comparisons. So RSV versus flu, RSV versus UTI, and RSV versus fracture. You can see the sample here. Remember, this is a match design. So it's always going to match to the lowest patient sample that we had, which was RSV. So we had about 2,700 for these two comparisons and only about 1,600 for RSV versus fracture. When we look here, so we now have four columns which represent each of our primary outcomes. We do have the incidence count and frequency. Obviously, again, a little bit different from the previous slide because this is within our matched cohort. And then we have for each is the hazard ratio. I bolded the hazard ratio if it was statistically significant. So you can take away pretty easily from this that heart failure, regardless of what we were comparing the RSV patients to or what patient group we were comparing them to, the risk of heart failure in that 1 year post-discharge was significantly higher in RSV. So about 26% higher for RSV versus flu and up to about 90% higher for RSV versus fracture, or a 1.9 times increase. You could also say our myocardial infarction was different for RSV versus flu, so about 50% higher risk for RSV versus influenza. We didn't see a difference for the other two groups. It was not significant, but we did see a similar trend for RSV versus fracture. Again, nothing for stroke and very, very wide confidence intervals, so we don't really need to think about that. And atrial fibrillation, we didn't see anything significant, although some of the confidence intervals got somewhat close to significance. If you see an asterisk, what that means is the assumption of proportional hazards for the test was violated, and what we're showing is the estimate at, I believe, 200 days post-discharge. So next, what I'm showing is the exact same layout, except this is for individuals that did not have a prior cardiovascular condition. So you can see here that the sample size is significantly lower. That makes sense because we know that these older adults tended to have, a lot of different types of comorbidities, particularly cardiovascular conditions. But what we can see is then more or less the trends stay the same. Obviously, we have much fewer events, so our confidence interval is a little bit wider, but we can see here that the hazard ratio or the risk is higher for pretty much every comparator group. Not significant for flu, but significant for the rest. We lose any significance for the remainder of the categories, and the confidence intervals become pretty wide. But again, we can see here that the number of cases went down quite substantially when we trimmed out the people with a prior condition. Now, for that group, so these are patients that had at least one of those four cardiovascular conditions. And we can see here that the hazard ratios follow the same trend. We see that the incidence of heart failure within 1 year post-discharge is significantly higher, regardless of the group that we are comparing RSV patients to. We can see here, looks like stroke, for one reason or another, was actually less likely to occur in RSV patients when you compare the UTI in this group. And we can see atrial fibrillation was significantly higher when comparing RSV patients to fracture. But I think as a whole, when you look at this table, we can see that all the really exciting stuff comes for heart failure, and trends that really follow suit. Doesn't matter which way we poke and press the data. So those are our primary outcomes. We'll move now into secondary outcomes. Exact same setup, excuse me, exact same setup as in the previous slide. We now have mortality 30 days post-admission, readmission in 30 days post-discharge, ICU transfers, and then length of stay. And what we can see here is more or less that RSV, compared to the other groups, is more severe. And this has been shown previously in the literature, so we were happy to see this. This is in all patients. So we can see mortality significantly higher as related to or as compared to influenza or the fracture group. We didn't see difference for readmissions. We see very large significant differences for needing specialized care. So that'd be a transfer to an ICU. And then length of stay was significantly higher as well, except for RSV as compared to fracture, where it's actually significantly higher for the fracture group. And that's probably not terribly surprising, particularly in a 65+ group. You'd expect that if they ended up in a hospital with a fracture, they would need to stay there a bit longer until they are ready to go home. So as before, if we look at individuals without any prior cardiovascular conditions, we see pretty much the same trends as we do above. Much higher estimates as well, so up to 3.5 times the risk of mortality, more than 3.5 times the risk of ICU transfer. And if we look at individuals with at least one prior condition, again, very similar trends. The trend kind of goes backwards here for RSV versus UTI. But for the most part, we're seeing the same things as we saw before. And the real takeaway here is RSV seems to be more severe. So just to summarize that, it looks like the incident heart failure admission post-discharge significantly higher for RSV patients, regardless of your prior cardiovascular condition status and regardless of the groups you're comparing to. And then mortality, ICU admission, and lengths of stay, pretty much all significantly higher for RSV patients with some exceptions. So this leads us to now the interesting part, is to figure out why, or at least to hypothesize why. Why the heck is RSV more severe than, say, influenza? And why would it really, or any ARI, lead to heart failure? So, okay, so I have, these little molecular maps here. I'm not going to turn this into an immunology talk, even though I'm an immunologist and I love this stuff. What I want to show here is, some of just the differences in the way that a cell responds to flu versus how a cell responds to RSV. So one thing to take away, we have flu here in a little blue circles. We have a cell. This could be a lung epithelial cell. This could be an immune cell. It doesn't really matter. And then we have all the bits on the inside of the cell, things that are responding or binding the pathogen, pathways that are activated due to the pathogen. And you can see here with the little red blocks here is how the pathogen is actually fighting back, is trying to subvert our immune response. So we have it for flu on top, we have it for RSV on the bottom. And the main takeaways, if you look at these nice little half moons, these are the things that are binding the pathogen and eliciting an activation response. We can see that RSV actually binds a set of receptors that influenza does not. So this is TLR4 and TLR2 and 6. They have been shown to bind the F fusion protein. I'm now forgetting that. I guess I need another coffee. And so these are innate receptors. We tend to look at them as binding pathogens such as Streptococcus pneumonia or E. coli, so bacteria. But they have been shown to bind protein from RSV. And this doesn't necessarily occur with influenza. So what this gives the cell is another reason, another weapon, another pathway in order to activate. And although this can be a very good thing, particularly in younger adults, there's many ways that we can activate our cells in order to fight back against an infection. That's going to be really good. However, in older adults, one thing we know about the immune system, even though we always talk about it in this immune decline sense or this immunosenescent type lens, often what we see is hyperactivity. So if you talk to Dawn one day in the halls, she'll tell you all about how cells from older adults are more likely to elicit this hyperinflammatory response. So one thing we might not want are more ways for the cell to activate. This is if we get overactivation, that may lead to greater severity, somewhat, akin to, say, a sepsis reaction or something like that. So that's one thing to show that's difference between the two. And then all these other things here. So again, I'm just pointing to where we see these little blocks, and these are how the virus itself is trying to subvert activation, because obviously the virus wants to go in the cell, it wants to use the cell machinery, it doesn't want the cell to know it's there. And the cell has figured out ways to take care of the virus, and then the virus has evolved ways to actually subvert all those mechanisms. And you can see that there's many for both viruses, and there's different ways that the subversion is happening. Apparently, RSV is very good. I'm not an RSV biologist, but apparently it is very good at subverting immunity. So this is kind of the opposite end of the spectrum. We don't want too much of a response. We also don't want no response, because that's going to obviously lengthen the infection and increase the severity. That could be another mechanism through which RSV is more severe than, say, a flu or maybe another viral pathogen, or something along those lines. So now I'm going to summarize just some of the evidence that's out there. There's not a lot of evidence comparing RSV to other pathogens. I think this is an area we need a lot more work. In rodent studies, they have shown that RSV, really, it seems like when they do experimental infections, there doesn't seem to be a difference in the severity, although it seems that in at least some studies, inflammatory responses may be greater and earlier than influenza. Mind you, this is in adult mice. This is not on an aged background, and that's very, very important to the context here. In cellular studies, there has been, some work to suggest that RSV exhibits really effective subversion mechanisms. So that's what I was discussing here. And there's also been at least one study to show that, when you stimulate neutrophils from asthmatics with RSV, that it elicits a greater inflammatory response than if you did so with influenza. Observational studies in people. One thing we know about RSV, it has a propensity to infect lower airways, so often related with wheezing. So that obviously can increase the severity. Another thing that's really interesting about RSV, and this is really topical given that the vaccine has recently been approved, which is a fantastic thing, is that we know that regardless of a natural infection or whether you're vaccinated against RSV, the antibody levels that you generate are likely to drop off a lot quicker than if you were vaccinated or infected with a flu or a SARS-CoV-2. And this is an important thing too. And one of the neat aspects about RSV is that reinfections within the same season are relatively common. I don't think it's as high as 5%, but I may be getting that statistic wrong. Whereas for other infections such as COVID or influenza, it's really not as common within that same season because you built up immunity due to the infection. With RSV, it's actually a lot more common. for this reason that the antibodies are just crashing really quickly. With that, on the cell-mediated side of things, it will also appears that a natural inflection to RSV doesn't induce a very good level of long-lived T cells. So that's going to limit the ability of the host to respond to an infection of the lungs and fight that off before the infection becomes severe. So this is a very much a summary of really anything that I could find in the literature. A lot of this is theoretical and hypothetical, which really points us to, us needing more work on RSV, particularly in older adults. Okay, so here's the next part. So if you thought I was waving my hands in the last slide, I really apologize here. So my cardiovascular, in particular my cardiac physiology, is probably 20 years old. So I really did my best here to understand why an airway infection like RSV could lead to a heart failure, which I didn't quite understand as an outcome before undertaking this study. So if you do know a lot about that, I apologize, but I'm doing my best. So let's start with the respiratory infection. So this is actually a diagram of rhinovirus, but I think as a whole, we can sort of treat all these different viral infections in the lungs sort of similarly. We have an infection. The infection is met by epithelial cells, which become infected. There's also resident immune cells here. This is at the luminal surface in the lung. And what that leads to is an immune response. So this is the subepithelial space. And what we have is a secretion of a number of different chemokines, cytokines, growth factors, all of which are looking to activate immunity, bring in more cells, but there's also a lot of off-target effects as well. So for example, at least in the case of rhinovirus, we have a secretion of these growth factors, which impact fibroblasts in the subepithelial space. It also leads to a deposition of extracellular matrix here on the airway smooth muscle, together along with some of these cytokines, which are activating some of these airway smooth muscle cells. It leads to airway hyper responsiveness. And then as a whole, with the differentiation of fibroblasts and myofibroblasts, more deposition on this airway smooth muscle space, is we have hyperplasia and hypertrophy. And this here could represent our pulmonary arteries. So if we zoom out, we can see here that this hypertrophy or this hyperplasia would lead to a constriction of our pulmonary arteries, which would lead to a condition known as pulmonary hypertension. So here's our heart and here's our lungs. We have the heart pumping deoxygenated blood into the lung, and we have our pulmonary arteries going in and picking up oxygen and then returning to the heart with that oxygenated blood, and out it goes to the rest of the body. Now, if you have constriction, though, in your pulmonary arteries, first thing you get is right ventricular strain. So here's our right ventricle. In heart failure, what you tend to see is an enlarged right ventricle. So since these arteries are constricted, the heart has to work really hard to push the fluid through. So this is why we get this enlarged right ventricle and a lot of strain. So it has to work really hard to get the blood through. It has trouble, so then you end up having reduced oxygen flow back to the heart. Because of that, you have a phenomenon known as demand ischemia. So this is where the heart cells are actually not getting enough oxygen. They're working really hard, but they need oxygen in order to thrive, and they're not getting that. And then as a whole, you finally get diastolic dysfunction, which is not a complete collapse, but a major reduction in the output from the heart. And that as a whole is heart failure. So that is one of the suggested ways that we could see that an acute respiratory infection could lead to an event such as heart failure, particularly up to 1 year later, because a lot of the phenomenon that we see going on, this pathological phenomenon like hyperplasia, hypertrophy, this takes time to accumulate, and that's why we can have these outcomes post-discharge. And you can imagine that if you have a pathogen such as RSV, if it is indeed a lot more likely to induce a stronger immune response then likely this whole system is somewhat on steroids, if you will. So anyways, that's sort of my best attempt at explaining our epidemiological data. Okay, so I'm going to end off here on not the fun stuff, but I think it's important to mention is the limitations of our study. So one of the main limitations is classification bias. So given that this does use administrative data, we relied on ICD-10 codes to identify or index hospitalizations. As I mentioned at the beginning of the talk, ICD-10 codes are probably not, not as specific for RSV as we want them to be, given that it tends to be underdiagnosed. And ICD-10 codes are just prone to misclassification. There's not a heck of a lot we can do about that. The more interesting form of bias that is likely at play, and that I talked about a little bit earlier, is selection bias, in particular a type of selection bias called partial verification bias. Because not all patients are likely being tested for potential RSV infection at the hospitals we looked at, and because of the underdiagnosis of RSV as far as in registries like our ICD-10 codes, it is likely that, or I shouldn't say it's likely, but it's possible that our index patient population of RSV patients really represent the more sickest of the sick. So really, it's just the patients that really needed to be tested. They had a very severe index case, which led to being tested for RSV. Another study that recently came out showed that RSV was likely going to be is more likely to be delayed in its diagnosis. So if a patient came in, was hospitalized, and their case resolved quicker than, say, some more severe cases, then they may not have even received an RSV diagnosis to begin with. So we wouldn't have been able to include that patient in the study. So this is a possible reason why RSV looks to be more severe in our study, because we have potentially more sick patients. However, our analysis of our secondary outcomes, such as mortality, ICU transfers, and length of stay, that follows suit with all the other studies that have been recently published. And those are studies that include laboratory confirmed data and are prospective in nature. So they are less likely to deal with this type of bias. So anyways, our limitations that need to be acknowledged. So just wrapping it up with about 15 minutes to go. What we showed, so incident heart failure seems to be more common in RSV patients relative to flu or UTI or fracture. This appears to be regardless of prior cardiovascular conditions. So whether you had heart failure coming into hospital or atrial fibrillation or not, you still similarly have that risk of a cardiovascular outcome within 1 year post-discharge, particularly heart failure if you're infected with RSV. And then our acute outcomes, so these were our secondaries, our mortalities, ICU transfers, and length of stay. They were also greater, as I mentioned, which supports what we've seen in the literature. So what we have, luckily, our vaccine is approved for older adults. This is a study that was published in The Lancet just, I think, a month or two ago. And what they showed that the effectiveness in older adults of the RSV vaccine, effective 80% against hospitalizations, 81% against critical illness. So that's very good and promising. And what do we need? Well, we need more multi-site prospective studies that includes standardized laboratory testing to really understand the true magnitude of severity of RSV infections as compared to other viral infections, but also other types of outcomes as well. And then experimental studies as well. So this is, people like our Dallin Bowdishes of the world to be doing work comparing RSV to other ARIs on an aging backdrop. So looking to see how is a response to RSV in, say, an older mouse or cells from an older individual or an older something or other that we can play with in the lab. What does that look like to help us understand why would RSV be more severe? So just to wrap this up, I have a number of people to acknowledge. So as I said before, this was an ICS study, and I could not have done it without support from our ICS North Hub here in Sudbury. So all the analysis was done by Joe Caswell. We had major methodological support from Josh Sarasulo. Dave Savage is the director at ICS North, and just fantastic to help give clinical insight into our analyses and our observations. Mark Tatangelo also helped us out with some of the analyses. The responsible scientist on the project was Jeff Kwong, program director at ICS and also at U of T. Jeff has just been amazing to help support this work and make sure that what we are seeing is interpretable and we acknowledging the correct limitations. So very grateful for Jeff's work here. And then also at Health Sciences North, our clinical folks, Attilio Costa Vitali, helped me understand what the heck pulmonary hypertension is and why that might be related to heart failure and ARIs. This work was funded by NOAMA. That was originally provided to Jan McElhaney, who we miss absolutely dearly, and I was privileged to take over this work for her. And the funding also went to Jose Therio here at HSN, and also thanks to Peter Austin, ICS, to help us with some of the methodology. To finish it, here is my contact info, and thanks. I'll take any questions.
Amazing. Thank you so much, Chris. Super helpful. I'll read out the questions that come in the chat, and I encourage anyone to write a question in the chat. So Dr. Tunks asks, is there pediatric data or age stratified data in adults for risk of heart failure after RSV admission?
Age stratified for risk of heart failure. I don't think there's nothing that I could find in adults, at least. So I was kind of myopic in my literature review looking in older adults or adults. Not a heck of a lot that I could find for RSV and pediatrics. Honestly, I haven't looked. Again, I was being very much age centric on the older spectrum as far as RSV outcomes.
What I think will be super interesting is seeing what happens in adult populations with the increased childhood vaccination, because there was just this great study that came out in Japan about rotavirus, which actually found they only vaccinated young kids and they saw a 60% decrease in older adults. So I wonder if your study would be harder to do in the RSV vaccine era due to possibly a herd immunity effect of starting to get kids
That's
vaccinated.
exactly, and it's the one thing I didn't mention as well, but I guess it's pretty obvious, is that, compared to the other major pathogens that we deal with, our strep pneumos and our influenzas and our COVIDs, is that we have vaccines for all of them. And RSV, we don't. So it could be that this whole story becomes moot within 10 years from the vaccination and also the herd immunity aspect. And that I wouldn't shed a tear for that at all.
So I have a question for you. I thought it was really interesting that your RSV participants were more likely to get influenza vaccinated. And I wonder there's no way you can know this in this kind of registry study, but do you have a sense that maybe because they were at higher risk or more comorbid, or perhaps they'd even had a previous experience with an infection that made them more likely to be influenza vaccinated?
Yeah, I would agree with you in that. We're looking at about 54%. So
still
not as high as we would want, but yeah, it's definitely a far cry from our UTI fracture group. I would imagine that it has to do for the reasons that you mentioned, that they had a lot more, prior conditions, particularly, 54% has COPD, and you would hope that group of patients would definitely be getting their flu vaccine every year. Obviously, they're not, but I would imagine that's probably predicating
in some ways, though, that's kind of like a good news story, because it means they're receptive to the message of vaccination. You know what I mean? If they're more likely to get vaccinated for influenza, then they'll probably accept the RSV vaccine. But obviously, we're not hitting our 80% targets of getting people influenza vaccinated, let alone that.
That's it. Exactly. Yeah. Then we're not helping out our vulnerable populations as much as we could. Yes.
Any other questions in the chat, or you can unmute yourself and ask them directly. I'll give everyone a couple more seconds to type any questions that they have. But I think, you know, the take-home message is pretty clear that we need to think more about RSV. And Chris, I'm curious too. This publication could have a huge implication in getting Ontario to expand their vaccination requirements, because right now we only really have it free for people who are living in long-term care, but it's recommended for people who have pretty much anything on that list. Anyhow, when it comes to publishing and sharing, I hope you'll reach out, and I'll reach out to the Lung Health Foundation and all our contacts to help promote RSV vaccination.
Yeah, that would be my hope for, these findings as well. I laid a pretty heavy hand in this talk to talk about mention the limitations of the study. However, that being said, I still think
Oh, no, did we just lose Chris? Okay, well, I guess that's our trial. I would say join me in welcoming Chris, but he seems to have disappeared. So thank you all so much for coming. I hope you got a lot out of it. Remember, vaccinations are super important, and we'll chat soon.